So this is the final presentation looking at radionuclide production, trying to address facts and fantasy. So part C. Hope you've had an opportunity to listen to part A and B. If you have, you would have already heard this message. If you haven't, it's just important to point out that radionuclide production in medical and research reactors is not the same as nuclear power reactors. They're completely different debates, they're completely different capabilities, and it's quite irresponsible to suggest that that the issues of nuclear power stations are the same or shared with nuclear reactor for medical production. They really are quite separate entities. It's worth pointing out that the favourable characteristics associated with reactors for radionuclide production that make it a quality service are the very characteristics that make nuclear power in the same reactor a waste of time. So they're not going to all of a sudden emerge or evolve into nuclear power reactors. So the three questions that we've actually looked at, or the three topics, in part A, we looked at whether reactors are efficient, both time and cost efficient, and in particular we looked at how the Australian model provides enormous economies of scale to provide a really good service to Australians. In part B, we looked at cyclotron production and whether the cyclotron production of technetium-99m in particular makes the reactor redundant. And of course, we showed the cost model alone, let alone the quality model, means that the reactor really should be here to stay unless we want to sacrifice the health and well-being of every Australian. And I guess the part C that we're going to talk about now is the other question that's come up through these debates is then, well, do we really need nuclear medicine? So that's part C. Do we really need nuclear medicine? And of course the answer is yes, absolutely. And I'm going to show you why. So what is nuclear medicine? So if you think about it, nuclear medicine is simply the injection, ingestion, inhalation or delivery in some other way of a radiopharmaceutical for the purpose of diagnosis and therapy. And a radiopharmaceutical is fairly simple. It's just a pharmaceutical, so like a medicine, that has a small amount of radiation attached to it. Now, the radiation, the pharmaceutical makes it go wherever it goes in the body, and the radiation allows us to see it for diagnosis, so we actually use that to trace biological pathways, or in the case of therapy, to deliver a radiation dose to those tissues and kill those tissues for therapy. So it's a pretty simple process. For diagnosis, we usually have an imaging system, and we use that to detect and quantitate. And when I say quantitate, what it means is that because we're looking at function and we're going to look at things in real time, we can actually do regional analysis that draw regions around certain organs and structures and monitor those over time and actually get numerical measures or values that actually outline what the function is at that time or over time. And so what we're really looking for is the biodistribution associated with each of those radiopharmaceuticals. So it's important to note that even independently of our radiopharmaceutical, that biological process that occurs, it's going to occur with or without the radiopharmaceutical. We're not asking it to change. We're not making the body change anything. Okay, sometimes we do interventional things where we might give a medicine that increases cardiac output or whatever, but the radiopharmaceuticals themselves, they do not do an alteration to the biological process. So if we wanted to stress the heart, to look at it, stress versus rest, the radiopharmaceutical won't do that. We'd use exercise to do that. And so it means that we're actually do two things. Number one, we don't change the patient. Number two, we have integrity. We're really looking at the physiological processes that are occurring. So it means it's very valuable information. Now, 70 to 75% of nuclear medicine studies in Australia and worldwide are done using a specific radiopharmaceutical that we've talked about in previous sessions, technetium-99m. We have it delivered once a week in a generator. It provides the daily technetium needs as well as after-hour needs. It's high purity, high quality, and produced via reactors. We also have reactor production of radionuclide therapy products like lutetium-177, iodine-131, samarium-153. But there are other radionuclides that we use that are cyclotron produced, like gallium-67, thallium-201. Another part of nuclear medicine is the positron emission tomography. It's a special kind of imaging that we do, and it uses a different suite of radionuclides. They're specific radionuclides that have different kinds of property. They don't actually provide the same imaging, but they're produced with small cyclotrons. Those small cyclotrons can't produce the gallium and the thallium. That's imported from overseas. So it's mainly fluorine-18 imaging. So how does it differ from X-ray? So fundamentally, nuclear medicine looks at the function of organs, and X-rays look at the structure. So they're complementary in nature. They integrate well and give each other information. So they're often done hand in hand. It's actually true that you can actually do some functional imaging using X-ray, CT, and MRI. And likewise, you can actually do some morphological or anatomical imaging with nuclear medicine. But I think it's fair to say that the X-ray technology is best equipped for imaging anatomy, and the nuclear medicine technology, which we call scintigraphy, has a level of physiology, a molecular level physiology, so it can't be matched with by some of the anatomical imaging. So nuclear medicine is capable of tracing the most intricate biological pathways by simply taking a compound that we know will behave in a certain way in the body and then letting it go and using the radioactive material that's attached to it, it's a very small radiation dose, to follow where it goes. And we should point out that the radiation dose that we use in nuclear medicine for most of our scans is typically less than a CT scan. So no one even thinks twice about having a CT scan in terms of the radiation dose because they're safe. But nuclear medicine procedures, the word nuclear sometimes scares people, but the reality is that the radiation doses are typically less, and not just less, but much less. So in nuclear medicine, we don't usually look at things, certainly not a bone scan, in colour. But what we can actually do is just to highlight this anatomy and physiology is you get this typical X-ray, and this is a bone scan. We put it in colour, so we are able to superimpose that. You can actually see that, that's, even without the X-ray, that this is the heel. Okay, so they've probably got a heel spur that we're going to be thinking about that's inflamed. But we can't see that anatomically, but we know that that's the heel. And we can actually see the different bones, and we have a reasonable idea of where we are. But to judge whether this is one side or two sides of a joint, especially when the structure of those joints are so tightly compacted, is actually a little bit difficult. And likewise on the X-ray, you can actually see this beautiful X-ray and you can see clear demarcation of all the different structures. But you can't actually see some of these processes. Like, you can't see a physiological change associated with the heel. You can see that there's something going on anatomically, but is that physiological? What's going on in here physiologically? When we combine those two bits of information, you can actually see that we actually get a combination of the physiology that tells us some very specific things about the building of bone in those zones, as well as the actual precise localization associated with the X-ray. So you can see the value of both the anatomy and the physiology. And we can do that with a number of organs. So this is obviously hands and wrists, being able to show the co-localization of the physiological changes associated with the anatomical localization. And in the pelvis, okay, so we're looking in our hips, okay, so you can see the symphysis pubis, pubic rami here, and this is bladder. Okay, so bladder often in this zone can cause a few issues because for this bone scan, the dose is excreted via the urinary system, so that bladder obviously is sitting right over the top of symphysis pubis, and you can still see pubic rami, but we'd want to empty the bladder to have a closer look. And this is a nice little fracture. You can actually see the line on the X-ray. And then you can actually see the physiological change associated with that mending fracture. So what are the applications of nuclear medicine? It's actually really important. It actually plays a crucial role in diagnosis, so both detection as well as localization of different diseases and conditions, which for some reason have gone undetected on other more simple techniques. So sometimes you won't see a fracture visible on an X-ray because there's no separation of the bone, or because it's associated with small structures in the wrist, or superimposed bony structures in the knee. But sometimes X-rays just don't show the fracture line because there's no separation. And nuclear medicine is very, very sensitive for not only detecting those mending fractures, but also localizing where it occurs. In some cases, nuclear medicine offers a simple, cost-effective alternative to more invasive, high-risk procedures. So, looking at a myocardial perfusion scan of the heart in someone with coronary artery disease is a lower radiation dose and lower risk than actually doing it with a coronary angiogram. And the difference is it actually gives you anatomy, so it actually tells you the hemodynamic significance of disease, which you're not going to get in a coronary angiogram where it looks at the anatomy of the vessel. So some very important applications there. Nuclear medicine, because it's looking at those intricate biological pathways, is extremely sensitive, and in some cases can detect diseases and localize diseases before you can actually see them in anatomical imaging modalities. So I say that because, with the exception of trauma, if you think about most disease processes, when you actually get an anatomical change on a CT scan or an MRI scan or an X-ray, that anatomical change, that thing that has grown, has been caused by a physiological change. The first change that occurs is change at molecular level, changes physiology, and then changes anatomy. So in many disease processes, we can actually pick up disease before any other modality, before there's any anatomical changes. And a really good example is imaging dementia. We can actually see the early changes associated with dementia, 5, 6, 7 years before there's any symptom development, let alone changes in MRI patterns associated with anatomy. In many cases is that the nuclear medicine scan is actually the lowest radiation dose compared to alternative methods. This is really important when you're talking about pediatric patients, women of childbearing age in particular, pregnant patients. There's a number of scans that we can actually do on pregnant patients because their radiation dosimetry is so well managed. So some of the examples is looking at cystograms, which is looking at reflux from the bladder. The radionuclide method is not only a superior method in terms of sensitivity of detection, but also is a lower radiation dose, typically to the child, than the X-ray alternative. And of course, when we're looking for pulmonary embolism in the lung, is that VQ lung scan actually has a lower radiation dose than the CT pulmonary angiography. Because we're looking at function, we can also use computer quantitation to assess function and get numbers associated with that. So we can actually look at curves and clearance curves and compare left and rights, which sometimes is the only clue that there's actually a disease present. So, for example, if you've got a renal artery stenosis that's causing renovascular hypertension, so uncontrolled increased blood pressure, then sometimes you can't actually see that in an image, but you can actually see that in the change in the quantitation because the actual function of the kidney changes in one kidney compared to the other. That gives you the tip that that patient has a renal artery stenosis that's functional. I've already mentioned that outside of trauma, many pathologies start with that functional change. And so, you can't do widespread screening of a population, but certainly in some diseases when they've got a family history or there's risk factors, then nuclear medicine can be used to pick up those diseases before symptoms develop. Functional imaging also allows early detection of disease, risk stratification, tailoring of patient management, differentiation of different pathologies like benign or malignant, and not only assessment of response to therapy, but early response to therapy. So you can see an early physiological change to know that the therapy that's being used is the best therapy. And if it's not the best therapy, you could change it early. There's also a number of therapeutic applications where we've treated a number of cancers, a number of other pathologies like hypothyroidism, malignant pleural effusions in the old days. We don't do many of those nowadays, but there's a number of therapeutic applications, and some of those are really important. Thyroid cancer, neuroendocrine tumour are really good examples. Prostate cancer is another one that's recently emerged. And then we have a whole bunch of advanced tools, like X-ray has its CT and MRI. Nuclear medicine has SPECT and PET, and we combine SPECT and PET with CT to actually have hybrid types of information. But we don't need to talk about those now. That's beyond the scope of this discussion. So I just wanted to give you a few examples, and these are only a very, very small snapshot of examples of the pathologies and the importance of the pathologies that can be detected. So in cancer, detection of disease, staging of that disease, predicting the response to therapy, and monitoring early response to therapy, I've already mentioned, and of course follow-up. Here's a quick example of a technetium-based study looking at breasts showing breast cancer. And this is in a patient where mammographic screening hasn't shown that up. Is that dense breasts and small breasts, and there's a number, and after surgery, very difficult with mammography. But this is a very sensitive tool for picking up breast disease or any sort of cancer for that matter. You can do parathyroid adenoma as well, for example. Heart disease is a raft of diseases from coronary artery disease, heart failure, Takotsubo cardiomyopathy, looking at pre and post chemotherapy associated with cardiotoxicity. So there's a whole number of cardiac studies that are done, and we look at detection stratification as well as treatment. And this is just a really simple example where you've got a patient who's looking at their heart after stress conditions and at resting conditions, and what you're looking for is a defect like this, well, it's stress that in this case it's still there at rest, which means that it's a fixed defect, which means it's an infarction, whereas you've got up here at stress you've got a defect that disappears at rest, which means that you've got ischemia. So it means that this needs to be medically managed. There's not much you can do with that. You can't go in and do a bypass graft or a percutaneous transluminal coronary angiogram. That would put the patient at risk. But for this territory up here, this is salvageable tissue, so it means that it justifies invasive therapy. Pulmonary embolism, someone jumps on a plane, flies to the other side of the world, end up with a clot in their leg that breaks off and ends up in their lung. And so this is a beautiful ventilation scan that shows normal ventilation to the lungs and the blood flow to the lungs, where you've got these characteristic wedge-shaped peripheral defects that show that this patient has pulmonary embolism. Biliary disease, there's a number of different biliary diseases we can actually look at, where you actually give the patient a radiopharmaceutical that's excreted through the biliary system, so your liver into the biliary system, you can see gallbladder, goes out to bowel. And if you see any changes in the physiology along that pathway, well then obviously it correlates with disease. In particular, we're looking for acute and chronic cholecystitis, but we can also look at gallbladder dysfunction. Kidney disease, this is an example where you're looking at function. Well, they're all looking at function, but you're doing quantitation. So we can actually draw regions of interest around both kidneys and plot them over time. So you can see that one kidney fills and then clears normally, whereas the other kidney just keeps filling and doesn't clear out, and that indicates obstruction. Bone disorders, there's a whole range of bone disorders from children through to adults. This is just a really good example of how sensitive it is for picking up bone cancer. This is prostate cancer that's spread to the bones, and this is a baseline and then follow up at week 12, probably after hormone therapy. And so you can see that the activity has decreased, and so has the PSA. Neurological diseases, epilepsy and dementia are good examples. So this is a normal brain for someone that's probably over 60. So you can see some changes, but that's what we'd expect to see normally. In someone with Alzheimer's disease, you can actually see this perfusion to the brain, and this is a product called HMPAO, which crosses the blood-brain barrier. So it actually goes into the brain cells and is trapped. So you can see that these parts of the brain, even the frontal lobe up here, there's decreased activity compared to a normal aging brain, and that's associated with Alzheimer's disease. And this is just a big thyroid goiter. So it's an enlarged thyroid. There's a number of endocrine disorders that we can look at. Parathyroids are another example, but typically thyroid is probably the most common one that we image. We can look at hot nodules and cold nodules. We can actually quantitate, measure the uptake. So in this case, it's 14.2%, which is abnormal. It should be less than 5 or 6%. And so as a result of that is that this is hyperthyroid associated with a goiter. We can also look at GIT system and look at transit. We can get people to swallow things and measure things, transit through their esophagus or stomach or through their colon. Another one is when they actually get bleeding in their colon, and so this is an example of where a patient has started bleeding in their colon. That they need to know where it is so they can go in and surgically fix it. So we're looking for not only the blood, but the earliest site that we can find it. So because that will guide the surgeon to fix that particular site. And then we mentioned therapy as well, and this is actually PET imaging rather than a technetium image. All the other images to date have been technetium, but because we're talking about the reactor production of technetium, or molybdenum to produce technetium in the generator, or cyclotron production direct. But this is lutetium-177 therapy. So lutetium is reactor produced. So this is all the disease. This is a difficult disease to manage called neuroendocrine tumour. And some of the therapy that we've been pioneering in Australia is looking at lutetium-177 lutate. It's a receptor-based product. And so you can see that they can use that to target the therapy, and then this is being used to monitor the therapeutic response. So you can see the disease course has improved over time in direct response to this treatment with this reactor-produced product called lutetium-177. So who benefits from the reactor in Australia and nuclear medicine in Australia? The answer is everyone, every Australian. ANSTO quote 1 in 2 Australians on average will need nuclear medicine in their lifetime. And that's been criticised by a number of political and social groups as being an overestimation. But it's actually not. It's actually an underestimation. And I'm going to do the maths for you. I'm not sure why people think that that's an overestimation, because the maths is pretty simple. And the numbers that I'm presenting you with are actually the numbers that the people that are critical of the 1 in 2 Australians have actually used themselves. So it's important to understand our healthcare system that we actually have the Medicare benefit schedule that is paid for by the federal government, and then you have your state-based health budget that's your public inpatients. And so these figures that we're seeing here, so there's 664,000 nuclear medicine procedures done annually each year in Australia. But that's the Medicare benefit schedule. So these are the ones that are covered by Medicare. This doesn't include the ones that are actually covered by the state government's budget for inpatients in public hospitals. And so this number could, it's hard to estimate, but it could double. It could be actually twice as many. I mean, if you think about all the big teaching hospitals in Sydney and Melbourne and Brisbane and Adelaide and Perth and Hobart, you know, in the regional areas like in Newcastle and Wollongong, where you have very large public hospitals, you could essentially be doubling the number of nuclear medicine procedures done annually, but they're not counted on the MBS. So these statistics that we're doing are only for those that are actually done as private patients on the MBS. So then if you think about the life expectancy of Australians is 82 years old, and we have a total population currently in this country of 24 million people. So that means that on average, every Australian would receive a nuclear medicine dose every 36 years. Okay? So on average, that's more than 2 nuclear medicine procedures in a lifetime, so 2.4 or something. So more than 2 for each Australian, and that excludes the public data that's not on the MBS. So essentially it could be 4, you know, at least 4. So on average that it most likely that every Australian would get between 3 and 4 nuclear medicine procedures in their lifetime. Now, of course, we know these are averages. No one's suggesting that everyone's going to have 3 or 4, because we're going to have some people that have 10, and we're going to have other people that have 0. But we have to look at it on average, and on average there's going to be, based on MBS data, at least 2.5 nuclear medicine procedures per Australian in their lifetime, but using all of the data, it's probably closer to 4. So in summary, the health and well-being of every Australian is dependent on the rich healthcare system that we enjoy here in Australia. Nuclear medicine is physiology and molecular level function that's not matched by other imaging modalities, so you can't do without it. It gives us information that helps patient care and outcomes that can't be matched by other services that we have in the healthcare system. And nuclear medicine is crucial in detecting and managing diseases throughout the life cycle, from neonates through to the elderly.